Hi, everybody. Can you hear me okay?
Yes.
Okay. Thank you for having me today in MISSABSCON. So today I'm going to talk about the endoscope in cervicothoracic junction. This is my disclosure. And my real disclosure, coming from the Bible and the Star Wars, Last Jedi. Also, my good friends in India as well. Looking forward to seeing you guys in person soon next year. Sorry for my non-academic presentation today. Because of my limited experience of endoscopic CT junction, this might be experience-based, expert opinion like that. So let's quickly move to the contents today. I'm gonna look over the review of our article and thought of the unilateral foraminotomy and medial prostatectomy and microscopic approach in CT junction and some case vignette as well. So you guys know the anatomical characteristic of the CT junction. It is the segment and level of the transitional zone between the mobile rhodotic curved cervical and kyphotic rigid thoracic spine. And also the spinal canal diameter CT junction is a little smaller than that of other spinal areas and watershed area where the blood supply in some patients may easily occur, right? And other evidence from 1994 from the renowned spine surgeon Howard Ahn, Rush University, and Alexander Bacaro, and the sort of the papers about the CT junction and the case solution, mostly they prefer the laminectomy and conventional instrumentation surgery with the local bone allograft as well. Almost all cases, any posterior procedures, they involving the CT junction should be followed by fusion, right? Is it true? What about this case, even though it's not the CT junction, concern about instantly following the total resection of the facet joint as well? This is my patient having the underwent the total prostatectomy and mass removal. I followed the nearly more than 100 months, and no instability is still there. So this is a pretty interesting paper about the morphometric analysis-surgical treatment of cervical posterior foraminotomy, published a couple of years ago. So we need to know the anatomical, morphological shape compared to the other subaxial cervical spine about the SAP height and facet joint width, like that. And there's the paper of systematic review and meta-analysis about endoscopic posterior foraminotomy. They have embraced the discectomy and foraminotomy and subaxial and the other all-level CT junction. So regarding the evidence, and all the article has limited the experience about the endoscopic experience of the CT junction. I published this article 2013. It is the surgery under the microscope guided because I felt that in CT junction it is pretty difficult to identify the location. So I love to use the OAM navigation to exact targeting the CT junction right here. So you can find, and moreover, I can find any remnant, the bony structures, once we check rescan the CT OAM scanning. This is one of the example how I made the cervical foramen discectomy at CT junction with the C8 palsy left arm. You can find the small disc fragment there. Right? I'm gonna quickly move to the end of the surgery. Once I've made the laminar foraminotomy, I can I was able to explore the ventral dura and eventually remove the small fragment. After that, patient weakness improved. And let's move on to the recent case of endoscope approach in city junction. You can find the acute progressing, the paraplegic patient with the huge hemorrhagic facet joint cyst at city junction. I used the arm navigation to navigate the exact target, the huge hemorrhagic cyst. Once I made the laminar foraminotomy, and you can find the hemorrhagic leakage from the cyst material, and take the fragment out. I published in the next journal early this year. So let's move to other case a bit yet. Very old male patient, 84 years old, intractable arm pain. Actually, I have done the MIS posture decompression multi-level from the 4, 5, 5, 6, 6, 7, not the 71, because patient have the underlying the kyphotic posture. A couple of years later, favorable outcome, no obvious arm pain over the 2.5 years. And suddenly, only this year, patient have the intractable ranulating arm pain along the C8 dermatome. You can see the very kyphotic posture. This is MRI done in sagittal and axial. There's the foraminal disc herniation at the C7 T1 level. You can also find T1 axial and sagittal view right here. What about the 3D CT scan? You can find the bony structures, bony foraminal stenosis osseous. So what about the pre-op planning from your side? Patient had the kyphotic posture underlying the really kyphosis. There's the obvious foraminal stenosis and disc extrusion. And patient age and the 84 high CCI is the complicated cases. Ideally, I'm pretty sure that one of you are the member of CSRS. So I think their decision mostly the big surgery, anterior reconstruction, and posterior screw fixation to make the ideal rhodosis, right? But let's see the patient, real unmet need from the patient, just the acute onset arm pain along the single C8 dermatome. So my operation is full endoscopic laminar foraminotomy in CT junction. This is post-op images. I made this a small part of the upper pediculectomy to make the enough space. In case of the cervical disc herniation, many patients require the partial pediculectomy to make the enough room for manipulating the nerve and the dural tube. So this is the post-op CT scan. This is the outcome. And what about the sagittal alignment? Yeah, pretty kyphotic. And once the pain gone, you can see the much pretty restored, even though it is not enough, right? But it became better. What about the operation scar? Just a small incision along the CT junction. What about, let's move the other recent case, arm assist endoscope cervical foraminotomy. Actually, this patient also has wrist drop and disease 8 palsy, and many previous surgery. His first surgery was done in 1999, 23 years ago. It started from this ACTF 4, 5, 5, 6, then the 4, 5 again, then the 6, 7 again, and then additional foraminotomy and screw fixation at 6, 7 level. This looks like the domino game, right? And the patient visit me because of the recent onset weakness and the tingling sensation right here. So you can see the X-ray, multiple surgery done before, and the posterior implantation, screw fixation as well. This is weakness patient had, and this is X-ray dynamic view, foraminal view as well. Let's see the MRI and CT scan. I think the patient in MRI itself, patient have both foraminal stenosis. A little bit the severe foraminal stenosis left side. That is why the patient have the left side C8 palsy. In right side, actually no obvious symptom at all. But MRI is you see the foraminal narrowing at CT junction as well. Central, no obvious central stenosis, only left side symptom there. So CT scan, both foraminal, osseous foraminal stenosis there. So it's quite challenging cases. I have measured the SVA cuffs angle, T1 slope, and neck tilting as well as inlet angle, right? And the patient diagnosed neurologic and clinical status. So we have sort of the surgical solution for that. Just for nerve decompression, I think the decompression might be enough. What about the instability? Yes, I agree the patient have sort of unstable spine at CT junction. That might be, fusion might be the solution for that. What about the deformed spine and imbalance? You might be wanting the cervical correction anteriorly and posteriorly. Very difficult decision. The already the subaxial spines from the 4, 5, and 6, 7 level already kyphotic. So if you make the perfect angulation, you have to do the osteotome removal, the posterior instrument as well, and the anterior redo surgery as well. I'm not sure. But, so I think we need to hear what the patient want to be treated. So that is the main issue for decision making. In case I agree, in case of myelopathy or bilateral radiculopathy, ACDF gold standard, I have done as well. Like this patient, but some patient sometimes I do in case of inevitable, even the transsternal anterior corpectomy and posterior instrumentation is a big and challenging cases. You guys know that I only do the endoscope surgery. It's not. I do this kind of challenging cases as well. Anyway, so my choices of surgical ideal procedures, yeah, I have to consider patient factors, surgical factors, and surgeon factor as well. So I did navigation, O-arm-based navigation, posterior endoscopic cervical foraminotomy at CT junction, only the left side. I don't have to do the right side decompression. Patient didn't have any kind of the weakness and the pain as well. This is the surgical planning and the operation view. Because of little time constraint, I'm gonna move to the final status. You can see the C8 nerve well, palpate the caudal pedicle and cranial pedicle as well. More extension of the, anyway. You can see the tip of the SAP already removed well. So that's all the procedures. Of 3D scan, we can assume the decompression margin like that. X-ray and outcome, not bad, but unfortunately, patient clinical neurologic status didn't improve, so no obvious the improvement so far. Anyway, this is my take-home message, but sorry, this lacks evidence because of limited cases. So I believe the posterior endoscopic cervical foraminotomy is safe and effective. There's no argument it is safe compared to the transsternal approach. Alternative to ACDF, low complication, similar pre-operationally, must be performed under the strict indication. I believe the anterior approach is gold standard. In case of CD junction, OM navigation, surgery helps determine the accurate entry point, confirm the sufficient decompression and bone resection. This is my talk. Thank you very much.
Thank you, Professor Luke. Any questions from the audience? Dr. Luke, you did recommend that navigation is essential. What difference in the technique, or why do you need navigation when compared to a cervical to a cervicothoracic junction?
In most cases, actual cervical spine, we don't have to have the navigation system, but in the deep-seated spine, such as the CD junction, when the patient is placed in prone position, especially male patient, we cannot identify where is the CD junction. Even the 6-7 level in patient obese, 5 is not invisible. So if you want to do the open surgery, it doesn't matter. You can palpate the C7 spinal process, and you can make the 5 centimeter big incision. You can figure out where is a 6-7, where is a 71 in your eye. But just 1 centimeter incision, put the scope inside, it's technically difficult. But I can say that we have the AP fluoroscope view. Yes, without the navigation, we can do the surgery. But I mean, precision need the ideal, the location. It looks like that's a role of navigation as your car already embedded in your car, right? Also the 5S as well, lumbar sacral junction as well.
Okay. Thank you, Professor.